Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and the creator of Finally Friday Live. And we are now live on the March 20th, 2020 edition of Finally Friday. And I do want to thank you for choosing to spend your precious time with us here on Finally Friday. And we are talking, as we have said in our emails and everything, this is about the hospital as the new frontier, and we're going to hear voices from the front lines in the fight against COVID-19. So today's broadcast is sponsored by our broadcast sponsors, who are the Health Law Partners, Dea Gaskiza's AR Systems, Mary Gregory's MAS Coding Solutions, and by Ensemble Physician Advisor Services. And these broadcast sponsors are the ones who provide financial support so that you all get to continue to watch the live shows for free. We also have and want to thank our broadcast partners who supply content and expert speakers for the shows, and they are Recovery Analytics, the Council for Certification of Medical Auditors, Phoenix Medical Management, and Core CDI. So I'm just kind of briefly going over that today because we've got so much to cover. Today's show, we are privileged that Ensemble Health Partners has put together this group of working hospitalists and their two physician advisors who are always with us on the shows, Doctors Kit Trin and Maria Johar, and they are all here today to share their experiences on the front lines dealing with the virus. And I'll have Dr. Johar introduce all of them in just a moment. But before we get going, I do want to make clear that the opinions shared on this show are those of the panelists, and they're not necessarily representative of their employers. My opinions are, of course, only my own and no one else's, and especially not those of our sponsors. And finally, we offer these shows for educational purposes only. We're certainly not offering legal advice of any kind, but we do our best to provide you with great, accurate, and conservatively considered education for free, and at least be able to point you in the direction of solutions. If you are not familiar with this Zoom room, I want to point out to you that there is a Q&A box where you can enter questions at any time during the show. Also, there is a chat room that is public. It is available to everybody who is online on the webinar. It is not kept after the show. I do get a copy of it, but I discard it because I don't want any of that stuff to be discoverable. So feel free to use it. You are, of course, entitled to enter comments or questions anytime as we go along. We do think of this more as a discussion more than a lecture, so please feel free to ask questions of the speakers as you go, if you will. Okay, let's, Dr. Johar, I'm going to have you introduce the panelists, and I believe they're all your friends as well, so take it away.
They are. Thank you so much, Ernie, for letting us share some of our thoughts with your audience. So you've heard Dr. Trin on your show before, but today we bring him in not only because he is our Chief Clinical Officer and Chief Physician Advisor at Ensemble Health Partners, but also because he's an actively participating family physician. And he was just sharing with us, how a lot of physicians are now transitioning into telehealth and telemedicine. So he's a phenomenal person to chat with. Besides being actively practicing physician, he is and has been a medical director for the Pennsylvania Medicaid program, chief medical information officer, and a medical director for some very large ambulatory medical groups, the VPMA, and chief medical officers of many systems. So he is a phenomenal expert in very many different areas. Dr. Muktaq Mathur, also a great friend and expert as a physician advisor for Ensemble, but he also practices as a hospitalist, and he's been doing so for over a decade. He's been a medical director of many hospitalist programs in Northern Virginia. He's also worked with the advisory board and CMS and the White House. So a great resource. The next person I'd like to introduce is Dr. Mihai Gavris. He's an internist by trade and has been a hospitalist for the past 15 years in various leadership and administrative roles. Michael Rowley, Dr. Rowley, a former, he's retired from the US Army and now serves as a physician advisor as well as he's family medicine trained and has worked in private practice, urgent care, hospice physician, and currently as a hospitalist as well. So most of them have come with years and years of experience. The last but not the least, I speak of Dr. Hassan Youssef. He's been practicing internal medicine for nearly 2 decades in very many different capacities. And he is one of our mentors as a physician advisor as well. They all work in some capacity in Ensemble Health Partners. And just a little bit about Ensemble. Ensemble was awarded the best in class for the revenue cycle outsourcing in 2020. They're connected to the bedside as well. Not just the revenue cycle, but the bedside. Patients are first, last, always. That is our motto. If you go on to our LinkedIn Ensemble website, you will see that there are many free resources available, whether you're wanting to optimize your Epic EMR, coding, billing updates, CMS waivers, or telehealth. We also have a great PDF and information on managing the panic in this pandemic. So back to you, Ernie.
Okay, great. Thank you, Maria. That's terrific, and it's great to know something about all their backgrounds. We do have with us Sharon Easterling is available with us today. She's a revenue cycle expert, and I've never been able to stump her in the 10 or 12 years I've known her. And then Bill Malm may be joining us later. He is a certified medical auditor, and that's usually how he talks about all of this with us. I don't know if Stephanie will be able to join us today. She's a case management and UR team expert. But anyway, let me go ahead and get started with what we're going to do on the show today. I've got some slides here before that talk about because I keep seeing people on social media talking about, apparently there's a lot of people who don't believe this is very serious. And so I'm just putting these things up sort of because they kind of surprised me, looking at them when I first saw them about how serious this. Now this is from a couple of weeks ago, showing that red square, showing how serious this is, as of February 28th. But of course, the problem with all of these numbers is that we don't really know the number of people who are infected. So at any rate, that was the best kind of indications at that time. Then there was this article that came up that was that Tom Frieden. He's the former director of the CDC, and he had this article and showing this chart, which then I've got the next slide shows some slides from CNN this past week, showing on what the death rate could actually be. These are pretty alarming. And then this one was on Fareed Zakaria's GPS show on CNN, and basically he was explaining how a lot of people don't understand this idea of how fast it's growing. It could be 3 million affected in the next 30 days. And this is just from last Sunday, was when he was talking about this, because it's doubling about every 3 days. And, it remains to be seen if we're going to be able to flatten the curve and how high is that going to get in the meantime. This was their slide of that same graph that I had up there just a minute, showing the, worst case and the best case possibly, 327 deaths versus 1.6 million. So this is obviously very serious. This slide comes from a dashboard that I found done by John Hopkins. I encourage you to go look at it yourself. It's very well done. The most alarming thing to me is on the bottom right when it's talking about, how many infections there are, growing throughout the world. And of course, the US is one of those, and this is 14,250. That's probably larger now, just since I pulled that chart this morning. Then here is a map that I found that's about the bed shortages. That may be something you want to be able to show to other people besides just your clinicians. Idea being that, as I believe most of you would agree, there is a severe shortage of beds in the country, and that was even before the pandemic. I thought this was very interesting, showing this map that comes from real data. I believe it comes from CDC data, but it's put together by University of Columbia. Anyway, then these were some images that Dr. Johar had found and shared with me over the past few days about what's being done. I thought the stickers in the elevators, that was amazing. I mean, I don't know who came up with that, but must have come up with it pretty quickly, and it looks like pretty interesting usage of stickers in elevators. And then somebody is putting out these pictures of the do's and don'ts about how to deal with trying to not spread the virus or catch it. I thought those were very interesting pictures and a great way to get the word out. I haven't seen anything like that in the US yet. And then this one, there was the power of social distances. I love this picture. Came to me from Dr. Al Gore, who's out of the West Coast. He shared it on the Rack Relief listserv this morning, and I put it up in the emails, and it's in this deck. And all of this, by the way, I'm going to make the deck and the recording for this all available for free on my website, and so everything is going to be available for anybody for free at any time. But I thought this was a great graphic as well about the power of social distancing and what it could mean if we could stick to that. So, okay. Dr. Johar, I'm going to let you take over from here. These are the 5 subjects that your speakers chose to talk about for this. So with that, I'm just going to let you tell me where to go from here. And we will, and my other panelists, if you have something to say, just let me know, and we'll jump in at an appropriate time. So Maria, it's all yours.
Okay, thank you, Ernie. And I'd like to say that, we got the experts from the bedside to share their concerns, their experience with our audience today. And Ensemble, of course, is always looking to redefine the possible in healthcare. So we brought, first of all, I'm going to ask Dr. Trin to share with us the impact on and in and when patients are coming from the SNF, and what is the state of affairs for patients coming and going to a SNF. Dr. Trin.
Thank you, Dr. Johar. Over the past week, I've gotten several calls from different clients, and I thought, okay, it's going to be about statusing or some financial questions. But interestingly, I got several calls on the same question, so I thought it'd be a good idea to kind of put this out there. And one of it concerns our most vulnerable population, those being nursing home patients. We know with the elderly and the comorbid conditions that these patients present with, they are the most vulnerable to succumb to the COVID-19. So the interesting things I've been hearing from these clients is nursing homes are bringing patients to the ED for concerns of respiratory symptoms, but they are not taking the patients back into the facility until the patient has been tested for COVID-19 and the results are back. And so obviously this presents a patient throughput issue. If you were to bring everybody in like that, your beds could potentially fill very quickly for people who don't need to be in the hospital. So that was one issue. What I have advised some of these folks to do is really about education. Nursing homes need to understand in an otherwise stable patient, hemodynamically stable, or afebrile, maybe they have a dry cough, and then everybody gets very nervous. But just like you or I, if we're healthy, we can self-quarantine at home. Certainly, the SNFs or the nursing homes should have the ability to, in many cases, self-quarantine the patient. And what the CDC is recommending is simply, well, not simply, but having the patient have their own private room, preferably with private bathroom, and have them self-quarantine there. Staffing would obviously have to wear appropriate protective gear. And then lastly, they do need to report this to their local health departments for further instructions. But so really trying to get the education out there to perhaps rightfully so nervous nursing homes. We know where the outbreaks have been the biggest is in nursing homes, but really just to educate folks. I've also have heard that after conversations, maybe CMOs or VPMAs will reach out to nursing homes and talk to the medical directors of the nursing home and kind of just keep each other abreast of those disposition issues. Another thing I have heard about is nursing homes being reticent to transport patients, for example, let's say dialysis. As we know, dialysis patient, they're usually 3 times a week. And so a patient who's ready for discharge and the nursing home hears, oh, the patient needs dialysis, they have maybe some reticence to say, well, why don't we move this patient to a facility that can do dialysis without transporting that patient out 3 times a week? And definitely, it presents a problem because, again, this is a population we cannot, we cannot expose unnecessary risk to. But at the same time, we have to understand that there are guidelines out there for us to follow, and education really is key. But to hear that I'm not going to take this patient back, I'm not going to take them because they need dialysis, those can cause concerns for hospitals that are already brimming with patients. Today's webcast, definitely you will hear later from clinicians and have some clinical guidelines, and definitely we will have a usual revenue cycle slant. So I just wanted to mention, aside from the SNF situation and how you should work with your SNF partners to make sure the education's there, the medical directors are involved to get these folks back to a right level of care. We've also had some payers who, because of staffing issues, have asked for peer-to-peers to be delayed. And we've also heard about delays in pre-certifying patients for SNFs, IRFs, things like that. My recommendation to those clients have been, please to keep track of these cases. Dr. Rowley will speak later about potential governmental help, whether they're grants or any things like that. But I do believe the ability to track the impact on your facility from the COVID-19 response of your system, everybody should track that. I don't know what the future holds with that, but tracking that's important. We know that ICD-10 for COVID-19 has been in effect since March 13th. And so I just, I would just end on my part with saying that hospitals are going to face several potential negative impacts, whether it's delaying or canceling the very profitable elective procedures. So that's a whammy there. A lot of patients will come in unemployed now. So there's no, the insurance may be questionable. There's been a tremendous increase in staff expense, I'm being told. A lot of times they're using, travel nurses or floater nurses, which are more expensive options. When you look at 2018, the average nonprofit hospital's margin was only 1.8%. And so I bring this up only that, let's track our denials, let's trend the payer impact, let's take care of our patients with the dignity and resources they require, but at the same time, be sure that you have processes in place that will allow successful appeals and protect your revenue. With that, Maria, any questions?
Yes, Dr. Trent, thank you so much for sharing this. I know that you have been talking to a lot of clients across the 40 plus states that Ensemble covers, but I was wondering, like you mentioned, if we are able to proactively work with some of our area SNFs, work with our payers, learn from some of our other collaborating hospitals in the area, maybe we can together have a better response in our communities. Have we seen anything like statewide or anything like that that you could share with our audience, Dr. Trent?
Yeah, so I think there are several efforts, including on the Ensemble side. Working with payers is a big thing right now, is making sure payers are aware of the impact, the negative impact to hospitals and clinicians, and just bringing awareness to them. We understand that they are also, in many situations, short-staffed, but at the end of the day, Maria, whether it's SNFs or payers, we need to make sure they understand that we are responding as directed from the federal and from levels. We are responding appropriately, making sure lives are saved, lives are protected, and we should not be. This should not be a situation where hospitals and providers are punished for responding to a national crisis.
Thank you, Dr. Trin. Great conversation. Ernie, can we go to the next slide, please?
Yeah, I was going to say though, there was a comment by Val in the chat box. He was saying that the difficulty for SNFs puts them in full panic mode, or like the deaths in Seattle and other areas, and also the shortages of personal protection equipment. So that's all having an effect as well, of course.
Right, and every hospital, Ernie, since 9/11 has gone through this emergency management, and each hospital system has worked with their collaborating hospitals in the area to figure out how they can continue the supply chain, how they can collaborate with all kinds of healthcare providers in the community to provide, like Dr. Trin said, the patients are always, always the focus. How can we provide the best care, keeping in mind that we need to keep the healthcare provider just as safe as we need to keep the patients? Yeah. And we've been dealing with contagious diseases from forever. So this has definitely come on us very quickly, but we are working within the confines of our processes and policies, which are changing, evolving as we learn more very quickly. So let's go to Dr. Mathur.
Okay.
Dr. Mathur, would you share with us, as a bedside hospitalist, how you are dealing with this new COVID-19 as patients come to the ED and to your service?
Sure. Thank you, Maria. Thank you for giving me this opportunity. My name is Muktak Mathur. I work as a physician advisor with Ensemble. I'm also a practicing hospitalist and the chair of Department of Medicine at Bon Secours St. Mary's Hospital in Richmond, Virginia. I'm going to talk a little bit about the pathogenesis and clinical course for this disease. And it's a evolving process right now. Things change on a daily basis. Guidelines change on a daily basis. So we'll talk about what's current right now, and it could change. There's a lot of research, a lot of data crunching going on right now. But I'm sure most of us are aware that COVID-19 is a single-stranded mRNA enveloped coronavirus. There's a lot of debate about the transmission. Currently, the CDC says that the most common form of transmission is still the droplet infection, usually within 6 feet of an infected person. It can also spread through contact with body fluids, including sputum, serum, blood, respiratory droplets, etc. There was some debate, especially some chatter in the WHO regarding uh, aerosolization of infection and whether this is airborne. And there's some data coming out that it can stay in the air for about 1 to 3 hours. Again, it has not been confirmed. So at this point of time, CDC is still maintaining that the route of transmission is droplet. But they do recommend airborne precautions on a COVID-19 patient who has been confirmed. The incubation period of this disease is typically 4 days. The range is 2 to 7 days. There have been cases reported from China where this has gone beyond 14 to 24 days, but those are rare. The signs and symptoms, fever is the most common sign. 77 to 98% of the patients presenting with COVID-19 infection have been noticed to have fever, cough, myalgia, fatigue, shortness of breath are all noticed in these patients, and they have a propensity of greater than 50%. Less common signs are sore throat, headache, hemoptysis, nausea, vomiting, diarrhea, basically all flu-like symptoms. So it's kind of hard to decipher from common flu and common viral infection, respiratory viral infections. The risk factors for severe illness is not very clear at this point of time. CDC states that most of the infection is going to be mild to moderate and would require supportive care only. But the risk factors for severe illnesses, for people who are greater than 60 years of age, having pre-existing respiratory disorders like COPD, IPF, ILD, patients who are immunocompromised, diabetics, cancer patients, transplant patients, other immune disorders, etc. The mortality is kind of right now, overall mortality is 0.9% per CDC in a healthy individual who does not have any pre-existing disease. People who are over 60 to 69 have a case fatality of 3.6%. People who are between 70 to 79 have a case fatality of 8%, and over 80 have a case fatality of 14.6%. Pediatric patients tend to have a milder disease with case fatality of actually 0% below 10 years of age group. Complications, usually the mortality occurs because of the complication. Complications include pneumonia, ARDS, acute respiratory failure, multi-system organ failure, etc. In terms of diagnosing, again, at the onset, I would say the COVID-19 PCR mRNA testing is the definitive diagnostic test. Some other findings that have been noticed are leukopenia and lymphopenia, elevated BUN creatinine ratio, elevated LFTs, a D-dimer greater than 1, elevated CRP, LDH, IL-6, elevated ferritin, and interestingly, decreased procalcitonin. Doing a procalcitonin can give us some idea about patients who have pneumonia, because a lot of time the presentation is kind of mixed, and a non-elevated procalcitonin with flu-like symptoms may point towards a COVID-19 infection with other risk factors. The imaging shows bilateral ground glass opacities. One of the things that CDC has been working on is cross-reactivity, because there's some false positivity in the testing that we do. Unfortunately, there's no data available about cross-reactivity from other coronavirus infections. and or other viral illnesses, including metapneumovirus and rhinovirus and other viral illnesses per se. In terms of treatment plan, again, no definitive treatment available at this point in time. A lot of research, lot of chatter going on. I'm sure all of us have seen President Trump talk about possible benefits of chloroquine in his press conference yesterday. Right now, there are two cohorts that they're dividing patients into. The first cohort is mild to moderate disease. Those patients may or may not be tested, but even if they're tested, they are sent home unless they have acute symptoms, and they're told to practice social distancing and self-isolation. A large number of patients recover with just supportive treatment, without any aggressive modalities. There are some studies that are going on for patients who have severe illnesses. There's a French study that came out which said there's some benefit of chloroquine with azithromycin, and it decreased the duration of the illness. There was some advisory from WHO about ibuprofen. I think that has been withdrawn. There was some thought that ibuprofen may exacerbate the disease, but that has been withdrawn. There's another study which came out which indicated that lopinavir and ritonavir both have shown no benefit. This came out from China in terms of treatment modalities as compared to placebo. CDC is recommending not to use corticosteroids, as there was some chatter about the benefits earlier of corticosteroid use, but they're saying that may prolong viral replication phase and may cause prolonged illness. There's some compassionate use of remdesivir and some other drugs, but again, it's still for compassionate use and off-label FDA use. I think there's a lot of work being done in terms of finding out a cure and antiviral remedications for this disease. I'll let Mihai talk about the isolation part, but one of the key, because we don't have a cure, one of the most important part for the disease prevention is isolation. In clinical settings, it is very important to prevent aerosolization of this disease. So if there's a patient who comes in with respiratory distress, it is recommending not to put them on a non-invasive ventilation, not to use aerosolized nebulizers, as all of them can cause aerosolization of the disease and airborne kind of spread of the disease.
Dr. Mathur?
Yes.
Can I ask a question here? When we were chatting this last week, you had mentioned that you had quite a number of patients that were sick enough to be in the hospital, and you had possibly sent the lab, for testing. Have you, or do you have any idea of how long it is taking for the tests to come back and clearly state whether they have the COVID-19 or they don't? Those kinds of any timelines that you may have seen at the bedside? Sure.
Excellent question, Maria. So I think the labs all are overwhelmed with the COVID-19 testing at this point of time. It's been a humongous issue getting the testing and getting the tests back. In terms of testing, I can speak for Virginia. Virginia, there are two separate protocols. There's a state-driven protocol if the patient is high risk, and by high risk they mean somebody who has exposure to a known COVID-19 patient, somebody who's traveled from high-risk areas, countries like China, Iran, Italy, or internally from places like Florida and New York, or somebody who has classical symptoms, and the state thinks that this patient is high risk. the state is doing testing, and that testing is usually a little quicker. That takes about 24 to 48 hours to come back. For patients that we send the test to LabCorp, which is the private entity, initially it was 3 days, but now it has kind of creeped up to 5 days. And because of the overwhelming number of texts that they are getting, sometimes it even takes 5 to 7 days. So it's been very frustrating for clinicians because we've been keeping these patients without an answer for up to 7 days. But the caveat to this is that CDC, we were on a call with CDC, and CDC recommends that if any of these patients are stable to be discharged home, one does not have to wait for the testing to come back. They can be sent home on self-isolation and social distancing for a similar period of time, for 14 days, basically. And they can be informed about their testing when the testing comes back.
Beautiful. Thank you so much, Dr. Mathur. We talked a lot about, possible isolation, even sniff isolation, social distancing. So I'm going to invite Dr. Mihai Gavras to share with us, the different kinds of isolation. What does it mean to be in isolation? Mihai, if you could help, educate our audience on that.
Yes, thank you, Maria. Can you all hear me okay?
Yes.
Yes. I'm Mihai Gavras. I'm a full-time physician advisor with Ensemble and also work as a hospitalist. I'm by no means an epidemiologist or infectious disease doctor, but this is clearly something that I think, healthcare providers, we all should be very familiar with these days. Of course, the public, everybody should know about social distancing, which people seem to be able to not understand exactly, and many people, unfortunately, not doing their part to slow the spread of the disease. I think there's still probably room to educate not only the younger people in the community, and probably hospitals have a vested interest in educating the public in their communities to minimize the impact, to protect against the escalation and the overwhelming of the healthcare system with the disease. This is what all we're trying to do. The virus itself, it's very easy to kill. It's very easy to destroy its lipid shell. It only lasts a day or 1 to 3 days on the environment. And so it needs contact, close contact, person to person to get transmitted. So I think all the efforts that can be put towards that, will help minimize the impact. In the hospital, in a healthcare setting, all this, takes a more acute and quite frankly, personal significance. In addition, kind of our definition of isolation, contact precautions is clearly evolving and is colored quite heavily by the widespread shortage of personal protective equipment. And I'm not sure if there are hospitals that actually are doing great in that department, but the state health departments, and I'm following our Virginia Department of Health guidance, including CDC. The state departments certainly adapted the CDC guidance and used that and put out strategies. It's kind of a stepwise strategy to protect the supply and ensure there's continued availability of personal protective equipment. From the basic conventional strategies to limit face-to-face encounters, to contingency capacity, including extending the use of the N95 respirator by repeated use with several patients, but also crisis strategies, acknowledging the fact that this is not commensurate with the current U.S. standard of care, but it's reasonable to be considered to implement during periods of severe shortage. And they include actually quite detailed guidance for healthcare providers to minimize the risk of contagion of transmission based on the distance between the healthcare provider and the patient, whether it's more than 6 feet, 3 to 6 feet, less than 3 feet, whether the patient is masked for the entire encounter or unmasked. So very specific guidance. And CDC, in their last guidance, actually does acknowledge that homemade masks and personal protective equipment not approved by the CDC will maybe used as a last resort. Hopefully we won't get there, but certainly they are acknowledging the possibility of severe scarcity of this protective equipment.
So,
yes.
In the hospital, we've been dealing with contagious diseases. We have isolation rooms and other kinds of, private rooms and options. So can you just share with the audience a little bit about who would we put in an isolation room? As a hospitalist, who are you going to recommend go to one of these isolation rooms? And if we are short on isolation rooms, what other options we could do to keep patients safe and also our healthcare providers safe?
Yes, well, you're right. What adds to the complexity of this is that we still have the seasonal viruses that complicate, the flu and all the other viruses that we normally don't test for, that complicate the triage and care and the management of the suspected COVID patients. So this is another strain on the limited resources. The majority of patients do recover and have mild illness, so you don't know if where to draw the line, really. And the societies and departments of health, they're scrambling to put out guidance related to that, and it's all this guidance should be available on your State Department site, like it is for Virginia, and it does include even every hospital, obviously, I'm sure has their own plan for dealing with these, but they do include things like things that would not be consistent with the previous standards of care as far as isolation. But the patients at the highest risk who've had contact with the known case, with a documented case, and have the highest risk certainly would be placed on a negative pressure room. They're very limited, and so it really comes down to the individual facility and the number of cases that are seen in the community as far as the intensity of the isolation.
Right. So Mihai, as a hospitalist, as you go into the different hospitals to do your shifts, you should be checking with what the latest information is, because this process is evolving every day rapidly. So I would suggest to every listener that they do look at their hospital information and their emergency management, whatever tips they're giving them on that particular day. What you knew 2 days ago may no longer hold true today. So be very careful and vigilant. Thank you, Mihai. And now we will go on to Dr. Rowley.
Well, hang on a second, Maria. We had a question in the Q&A box.
Yeah.
And Dr. Yusuf has said he'd like to answer it live. Yes. The question is negative pressure more effective than regular isolation? I think Dr. Gavris might want to chime in on that as well.
Yeah. So Arnie, can you hear me?
Yes.
Yeah.
So, I'm a practicing hospitalist, part-time, full-time physician advisor. So I'll try to take a stab at it. Mihai, you can also chime in, as Arnie said. The negative pressure theoretically makes sense, But the hospitals are used to the droplet precaution. We have been doing it for many years, and it shouldn't be very hard to imagine that coronavirus, essentially COVID, should be treated as we treat flu, except the contagiousness of the virus is higher and the volume of patients that are coming in due to the epidemic is overwhelming. To answer the question again, the negative pressure makes sense. The hospitals don't have that many negative pressure rooms. So extreme complicated patients would be put into the negative pressure room. But other than that, we're just using the droplet and contact precautions for these COVID suspected or infected patients. Thank you.
Thank you, Hassan.
Maria, can I just chime in? This is Muktak Mehtar.
Yep.
I completely agree with what Hassan said. Just a quick point. If you put a patient on NIV, if there's any risk of aerosolization, that's when the negative pressure room becomes absolutely essential, because then essentially you are at risk for aerosolizing the infection. So for patients, the subclass that is on BiPAP, CPAPs, using nebulizers or any risk for aerosolization, that's when that cohort should be on negative pressure room.
Thank you. Thank you, Muktak. Makes total sense. Let's, Mihai, do you have any other suggestion, or should we go to Dr. Rowley?
No, I think obviously the negative pressure rooms are going to be used for the highest risk patients, but since they're limited, I think it does come down to assessing the actual risk that the patient has of having COVID. The patient has a known COVID infection, and I think for the most part, using an N95 respirator and strict contact precautions are what's needed, other than the cases where there's aerosolization,
Okay.
like Dr. Mathur just said.
Okay, thank you so much. We'll go to Dr. Rowley now, Ernie. So Dr. Rowley was serving in the Army as well. And so Dr. Rowley has a different take on this. So I'm going to let Dr. Rowley explain to us, what does the Presidential National Emergency Declaration do for us, what happened in the past, and what could possibly happen in the future. Dr. Rowley.
Hey, Maria. So the declaration of the emergency state by the president is kind of interesting, as it allows the president to exercise extra powers, which are going to be, I think they're going to be very key to the not only just the healthcare industry, but the nation as a whole as we move forward. Essentially what it does is it allows the president and the agencies under his control to release funds and to authorize grants and subsidies to industrial organizations, the healthcare organization at large, and to local communities and the states to provide funding for this emergency as it progresses. We already know we're already having a significant economic impact, and that actually may be the largest impact that we feel, even much more so than the healthcare impact that we're seeing of the actual disease. And social isolation is causing a significant economic impact. And so the Emergency Powers Act is going to, the National Emergencies Act, the Emergency Powers Act, the Stafford Act, the War Powers Act, they all kind of link together. And what they allow the president to do is some of the things we've already seen him done, maybe we haven't noticed it as much, but the president has been bringing organizations in and tasking leaders of organizations to say, we need your help to do this. And the interesting thing is he's not asking them, he's telling them, because the War Powers Act authorizes him to mandate that privately owned companies and to assist them in the action of changing productivity. So for example, he can go to the suppliers of PR95 masks and say, I need you to pick up production. We need more testing kits. We need more isolation kits. We need more toilet paper. And the effect of that is going to be twofold. One, is going to make the ability for us to tolerate the emergency as it evolves easier just through a supply chain effect, but also, hopefully, it will decrease the amount of panic that our patients and our peers feel, because honestly, that's probably even more important. Being military, I've been in lots of situations where supplies run short. We have to make do with what we have. We have to adapt, improvise, and overcome. And in the private sector, we're not necessarily as used to doing that. So this will hopefully allow us to not only decrease the impact of shortages that we may see, but also ease the panic that those shortages may cause, because we'll be able to expand the sense of help is coming. And that's a huge benefit to us in the healthcare industry and to our society at large. I'm sorry, do you?
No, go ahead, Michael.
I'm sorry. I'm not certain if anybody has specific questions on that, but how it may affect us. For example, any private industry that holds a government contract, that there's going to be significant effects. Another one of the things we were concerned about is through the War Powers Act and the National Emergencies Act, the president's already instructed CMS to relax some of the requirements that they have. So, for example, the three midnight stay requirement for patients going to a nursing home has been suspended, and I don't believe there's been an end date to that suspension. And so that would allow us. We get a patient, and we go to this patient. We can't isolate them at home. We don't want to keep them in the hospital. We have a nursing home with a bed where we can isolate them. It allows us to do that and bill that back to Medicare. And so those actions are our first step, but also any payer who has a contract with the federal government, it allows the president to take that payer and say, we're going to mandate that you do this. So for example, they could go to Humana, Blue Cross, United, and say, all of you have contracts with the federal government, and so now all of you must comply with the same rules that we've given Medicare, Medicaid, and the CHIP programs, the child insurance programs. The other thing it allows is for localities and states to request emergency assistance. So the president has declared a state of emergency. So for example, a governor or even a mayor of New York, for example, could say, I'm requesting that you declare us a disaster area. And that, if areas are declared disaster areas, that opens up a whole new wave of assistance and funding that can occur. So that allows for those localities to receive more monies, for the people in those communities to receive reimbursement for expenses that they had during that disaster. And so
this is Ernie. Does that kind of thing that requires, though the president is really the only one who has that kind of power to declare that kind of thing?
To declare it, so that can be done several different ways. The easiest way is once the emergency has been declared, if, say, for example, the governor of New York would say, I want to declare New York a disaster. I don't think it's there yet, but say that things progress. Then that would immediately allow the president to release up to $500 billion at his disposal to deal with that through the emergency disaster fund. And then he can go to Congress and request more money. He can also go to the Treasury and say, I want you to release funds that were already allotted for other things. So he has a lot of latitude to release monies. And that can be incredibly powerful because the economic impact of the state of New York saying, we need this, but we don't have the funds to ask for that. It allows the bankroll of the federal government to come in and help that. The interesting thing is that does, talking about, I think that one of the most important things that we're going to have to deal with, and we've already had to deal with, is more the panic that's being caused by this emergency than the actual emergency at this point. And so what that does is allow for an immediate action to give people essentially a warm, fuzzy feeling that, hey, things are happening, there is help available, and that help is being activated. And so, one of my favorite books is, Hitchhiker's Guide to the Galaxy. And the first thing you do is press the "Don't Panic" button. And this is basically the national "Don't Panic" button, and it allows us to activate all of our systems. So these are very powerful things that I'm not sure that everybody knows exist. And of course, the challenge with that is we don't know exactly how they're going to play out, because it requires an interplay of several organizations. It requires an interplay of the local governments, states governments, the president's team, FEMA, Centers for Disease Control, and National Institutes of Health. But my opinion is that all of those organizations are proactively working together at this point, and I don't think that's going to be a limiting factor.
Thank you so much, Michael. I know that we are kind of sort of short on time, but I did want to make sure that we addressed the specifics of, what do we do when we have a COVID-19 suspected or possible patient. And Dr. Youssef is very experienced physician advisor as well as a working hospitalist. So Dr. Youssef, if you could please share your thoughts on what are we going to do with these patients, inpatient or outpatient?
Thank you, Maria. So the challenging part is, we are in a crisis mode. The hospitals are running short of available beds, cutting back on even elective surgeries and procedures, right? And in the middle of this flu season, we have this overwhelming season of COVID-19. So how do we hospitalize these patients? Who should be hospitalized, and how do we status their cases? As Dr. Trin reminded us yesterday, that each patient, each case should be judged by its own merit. So there should not be a blanket statement that just because we are suspecting that the patient has COVID or might be a high-risk patient for COVID, that the patient should be inpatient. So that is the first thing that I wanted to clarify to all of us here.
That's good advice.
Yeah, that COVID does not necessarily entitle us to lose our thinking process. We should think through the regulations that we have signed up for. Going to the payer, we have the big CMS, the pure straight Medicare patients. If the doctor's documentations support and the laboratory tests, just like Dr. Mather said, liver functions are elevated, other parameters are suggesting the patient might have COVID, then the documentation will support, and a Medicare patient might be at a high risk, and these are usually older folks. They might be at a high risk of deterioration, which invokes then the presumption of 2 midnight from CMS guidelines. So if that is met and the doctor thinks that the patient might need 2 or more midnights, then the patient should be inpatient. That's for the Medicare patients. For the commercial version, like Medicare Advantage plans or the Blue Cross and other commercial payers, most of them follow MCG guidelines. Some of them do interqual, but again, the case should be evaluated by the patient's illness and merit of the documentation. And we will apply the MCG guidelines. One of our physician advisors, Dr. Miller, yesterday brought out that the MCG criteria for SIRS can be invoked where there is no particular focus of infection, but there is a systemic inflammatory and infectious changes going on, such as tachycardia, blood pressure, and hemodynamic changes, liver function, and other changes. If we use that, we can qualify a patient who is going to need significant resources in the hospital to remain as inpatient. And that's where physician advisors come in very useful, who can help the doctors guide the at least the status of the patients who are hospitalized. Thank you.
Thank you, Dr. Yusuf. Back to you, Ernie.
Whoops, had myself muted. Okay, that was great, and I think that's great advice from Dr. Yusuf there. But it really just boils down to the same thing we're always talking about. You do have to consider things case by case. There was a question I saw somebody put up on Rack Relief listserv while we were doing the show. They were asking if anybody thinks there's going to be any lessening of the rules for physician documentation in the setting of this emergency. And I think, given that what we just heard from Dr. Rowley, I think the only possibility of that is if the president decides to do that, just like he's done with the 3-day rule. So I think that's the only thing we can do is keep watching and see. Would the private companies do that? I kind of think they'll just follow along with Medicare, whatever the president does. There was a good question in the chat box here just a moment ago about is there a possibility of mutation with this virus? I don't know if anybody wants to try and talk about that. But I think, as with any virus, I mean, this one was a mutation, if I understand it right. So I think there is going to be mutation. So we'll just all have to, we'll have to see what happens. I don't know why there wouldn't be.
There is a question in the chat box about, does the waiving of the 3-day rule apply to the critical access hospitals? Yes, there is. If you go to the Ensemble LinkedIn, we have the CMS waiver on there. It talks about the 3 midnights for the SNF. It talks about the 96 rule for the critical access hospitals. There's a bunch of information out there. There's free information that is affecting a lot of different aspects of the whole healthcare industry. I would say that given that we are short on time, this is an evolving issue. We probably will need to keep coming back to the COVID and updating our listeners, Ernie. So we probably should, look to having an update on this as long as this lasts to see what else is going on. But this was a wonderful discussion. I think, Ernie, thank you for providing that platform. Yes. And to what Dr. Rowley's point, we have hope. They are bringing in a lot of resources, private and public and government, to help us reduce the effects and flatten the curve. But each one of us, every single one of us, can contribute to flattening that curve by being safe, by doing social distancing, by washing our hands, and doing all the right things that we've been told to do for years. But now it is affecting us and affecting our near and dear ones. So it is really important that we follow the guidelines as much as we can, and follow and be as compliant as we can. Look at the hospital's policies and procedures as they evolve, because the leadership in each hospital is bringing and sharing with their staff. So stay tuned in. And back to you, Ernie.
Yes. And the last thing I want everybody to think about before you get off the webinar is answer this. What was the biggest thing you got from today's show? I'm not asking you for my education, but your own. This is neuroscience, okay? The last thing you think about when you watch something like this is that's the thing that you will remember the most about the talk or the webinar that you watch. So write it down for yourself at least. You can type it into the chat box if you want. I love all that, because I don't want you to feel like the picture of that gal there. I want you to feel like this, that you got something really good out of the show today, and that it helps you And everybody that gets helped, you can help people on your right and left. So, oh, somebody was asking, possible to review their mortality rates again with the ages. I'll put that back up in a minute, but we are basically at the end of the show. That's all we've got time for today. And so I want to thank everybody for participating today. This has been great. We will be back again on Friday, April 3rd, and we may have another show about how all this is progressing, because who knows what happens in 2 weeks. Everybody stay safe. Thanks for joining us today. We owe thanks to our sponsors and partners, especially Ensemble for putting this together today. And please share the links to the show with your colleagues and friends. And I will be posting a link so that everybody can get this recording or can listen to this recording and get the slides for everything we had up there today. And just please keep in mind, you are my heroes, all of you, because you work and touch people's lives every day. You put yourself on the line. I admire that. So keep calm, carry on. And you know, as I said before, this is what we need to put on our wall. Dear COVID-19, we're coming to slay. You are not going to beat us. So anyway, thanks everyone for being with us today. And we'll see you on our next show when it's again finally Friday. Have a great weekend. And for that person who asked about, I'm going to try to find that slide that they were asking about and put it up again about the ages. Actually, I don't know if I had a slide that was about ages.
Dr. Mathur had shared it, and what we can do is, Ernie, we can give that information so that you can share it when you share the slide deck.
Okay, all right, excellent, great. Thank you, Dr. Johar. Thanks to everyone, and we'll see you next time. Have a great weekend. Bye-bye.
Ernie, are the panelists staying? No. Okay.
Yeah, no, we don't have a.
Oh, okay. No,
I don't have a way to just
Have
talk to the
yeah,
panelists.
have-
Thank you. Bye-bye.
Okay.
Bye-bye.
Thanks very much. Bye-bye.